ما ادري هو. الو.
شكرا دكتور بشوي. في ديسكشن بعد ديسكشن نهاية السيشن. I would like to invite زميلنا العزيز ضيفنا الدائم الدكتور محمد كلوب من غزة العزة في محاضرة قيمة جاسترو دودينال ارتري انوريزم رير كيسز اوف اوبستراكتيف جوندس. تفضل دكتور محمد.
صباح الخير.
اهلا وسهلا.
تسمعوني الآن؟
سامعين تفضل. شير يور ليكشر.
اوكي. صباح الخير، تحياتي لكم اخواني اصدقائي في اليمن السعيد. انا اتحدث الان موجود حاليا في روسيا. لقد خرجت من غزة في بداية الشهر الرابع، نهاية الشهر الثالث، لظروف يعني صعبة جدا. حاولت الرجوع في شهر مايو الماضي، ولكن لم نستطع للأسف الشديد. كان المعبر قد أغلق. سنتحدث اليوم عن حالة رائعة جدا، هي أول خروج لي فيها على الانترناشنال أرينا، لأنه صراحة كنت حابب أنه تكون عندكم في اليمن لمدى أهمية هذا الموضوع ومدى ندرته. أعتقد لذلك هذا هو أول خروج لي بهذا الموضوع في اليمن. وأنا أقصد ذلك لإخواني في اليمن كي يكون هناك نوعا من التنوع. وإن شاء الله سنشارك بمحاضرات أخرى، ويتم إن شاء الله يكون في لنا حضور مباشر لكم لنا ولكم في اليمن إن شاء الله. تحياتي لكم أصدقائي. Today I will talk about gastroduodenal artery aneurysm as a rare case, a rare cause of obstructive jaundice. It is a case report. هذا المريض يعني اللي اشتغلناه، أنا اشتغلته في عام 2022، 2000 أعتقد 21 أو 22 لا أذكر بالضبط. ولكن يعني كانت الحالة يعني رائعة رائعة، أنه نادرة، لأنه هذا المريض قد حضر إلى المستشفى والجوندس، ودخل في الأول قسم الباطنة، وبعد ذلك استدعى أخصائي الجراحة، وبعد ذلك يعني دخل في عدة أمور أخرى لم يعرف السبب فيها. انعمل له ERCP ولم يستطيعوا فتح القنوات المرارية. تم عمل له CT أنجيو وتبين ما سأقوم لكم بذكره حاليا. My colleagues who helped me in this very big work, Dr. Ahmad Al-Houd, consultant, general surgeon, head of surgical departments, European Gaza Hospital in Gaza. Dr. Mohammed Matar, one of best my consultants, interventional radiologist in my team, in Department of Vascular Surgery in Al-Shifa Hospital and Department of Radiology. And my students, Dr. Mohammed Hawahi, Abdurrahman Sheikh Ahmad, and Mohammed Al-Sha'ir, who help us in this operation. And they make some new about this study, about this case. Gastroduodenal artery aneurysm, rare category of visceral aneurysms, artery aneurysm, incidence of 0.01% to 0.2%. It's very rare. Incidence of 10% among chronic pancreatitis patients. Risk of rupture is considerably high, up to 75%. Mortality rate from aneurysm rupture to 21%. Intra-abdominal and retroperitoneal rupture, 19% mortality rate can be. Intraduodenal rupture account for the higher mortality rate to 21%. Our case scenario, 56 years old male, married and non-smoker, yellowish discoloration of skin and sclera 3 days prior to his becoming to our department becoming to for presentation in our department. Abdominal examination was unremarkable. Vital signs within normal, but CBC, as you see, hemoglobin is 9 and 5, and total bilirubin 5.5, and direct bilirubin 0.8 milligram, and amylase and others liver functions are within normal. Dilated intra and extrahepatic biliary tree in ultrasound imaging, and common bile duct of around 12 millimeters. Aneurysm of hardly identified source in the upper right abdomen. It is by ultrasound. And the imaging of CT angio, as you here, is very big, huge aneurysm in the right upper abdomen, abdomen, and causing a mass effect to obstruct the common bile duct in this area, and it is around 7 to 7 centimeters. It's very big and huge aneurysm. This is one of our first angiography, which is done selectively directly to hepatica propria, and as you see, the aneurysm from the gastroduodenal artery. It's very nice, as you see, very big and huge aneurysm. I tried to implant with my colleagues here in this area, because we have very nice something long neck from the hepatica propria up to the area of the aneurysm. I tried to implant, as you see, coil, but it failed. The coil is failed. And the second trial we put here is, as you see here, is bulldog umbrella, and it was closed. An excellent result here. And the aneurysm is without any blood flow here. But what happened sometime later, some days later? It is very nice to know this one. Post-operative course, 2 days post-intervention, the patient had normal bilirubin. Discharged home with good general condition. 10 days later, presented with worsening, voyage, upper abdominal pain, signs of obstructive jaundice. Total bilirubin level 402 milligram, and direct bilirubin 0.6 milligram. Here you see CT angiography was ordered, and indicated the thrombosis of the aneurysm with signs of partial backflow filling. We had a backflow filling from other arteries, from gastric sinister arteries and other arteries, which very rich in this area when we have very huge aneurysm as this one. And you see that the thrombose was also a cause of more mass compression toward the common bile duct and other anatomical points very important as portal vein. Here you see the aneurysm and the filling. So as a surgeon, we decided that we could not go other time to stop the retrograde flow from the other side. It will be extremely difficult, and the mass effect, compression effect is here is very seen. So the anatomical area, as you know, that here is hepatoduodenal ligament. It is very strong ligament. You know this one. It's very important to know the anatomy in this area. It's very strong ligament, and the mass compression also due to this one, this anatomical point is very important. It compressed all the anatomical points on this region, and it is very difficult region. The head of pancreas here also, it's nearly to this mass compression. Surgical exploration was done to relieve CVD obstruction. Midline incision with extended right subcostal incision to allow very good access to the aneurysm. The dissection took place to expose the aneurysm from the surrounding duodenum and head of pancreas. It was we had very big difficulties through the exploration to don't touch the tissue of the pancreas. You know this the pancreas is very delicate organ. The aneurysm was not pulsating inside after control and proximal and distal control, but we had a proximal control by the bulldog and distal control by other clamps. This is the aneurysm which was which when we started the surgery, as you see here. The content was extracted with intra-aneurysmal closure and debulking to relieve the mass effect. Serial postoperative follow-up revealed improved bilirubin parameters with good general condition. Drain was removed on 7th postoperative day, and a patient was discharged on the 14th postoperative day in good general condition. Here, the patient underwent MRCP, which revealed normal CVD diameter. As you see, normal CVD diameter without intra or extrahepatic biliary tree dilatation. About the discussion, we can talk that literature in 1956 to 2012, 74 cases describing gastroduodenal artery aneurysm, Japanese and English literature. GIT hemorrhage, most common clinical presentation, 52% of cases, and 7% of cases are asymptomatic. Non-specific symptoms, vomiting, diarrhea, jaundice, secondary can be. Jaundice secondary, of course, can be. The pathogenesis is not fully understood. So chronic pancreatitis, trauma, hypertension, and atherosclerosis can be caused here. The good standard diagnostic is visceral and angiography. It's 100% you can diagnose this one, and 67% under ultrasonography. Once diagnosed, must be treated even if small or asymptomatic. Management approach depends on presentation and hemodynamically. Hemodynamic unstable surgical intervention urgently. This one only for unstable cases. Hemodynamic unstable surgical intervention urgently. Don't do anything. Asymptomatic or stable cases, endovascular intervention can be coils, stents, grafts, or closure device as done in our case. Thrombin injection under ultrasound guiding has also been described. Gastroduodenal artery aneurysm difficult to be clinically thought of as a cause of obstructive jaundice. Once diagnosed, should be treated. Coil embolization is a feasible cost effective intervention, but can fail. Also can fail. The cause of occlusive devices. The use of occlusive devices used with extreme caution. Surgical intervention. Unstable patients with mass effect. And our case, he was with mass effect. We welcome you to behalf of the doctors of Gaza Strip. Thank you for your support despite the difficult situation. We are always,
محمد شكرا
all the
جزيلا.
time, trying and going for develop.
نشكر
Our
حضورك.
dream to work in a free Palestine, rising our level, raising our level, achieving results unattainable for our enemy.
في فلسطين ان شاء الله in the future ان شاء الله بالقريب
Thank
العاجل.
you very much, my colleagues. I think that this case report is one of very rare which you I think you see, and I can't talk that in this case we used the new and the old. We used the interventional radiology with very high qualification, and we went for surgery because the mass compression is extremely was difficult, that our doctors could not implant any stent in the CVB. Thank you very much, and I hope you successful in this very nice conference, Free Palestine.
نتمنى حضورك الدائم في كل مؤتمر، ونتمنى حضورك عندنا هنا في صنعاء ان شاء الله باذن الله.